Let me start with a question that most people have never been asked directly. Do you know what your actual cardiovascular risk is right now? Not a vague sense that you should probably watch your salt intake or walk more. Your actual, calculated, evidence-based risk of experiencing a heart attack or stroke in the next 10 years? If you answered no, you are in the overwhelming majority. And that gap between what people know and what they need to know about their own cardiovascular risk is, in my view, one of the most significant and most correctable problems in preventive health for adults over 60. I am Dr. John. I work in preventive health and senior wellness. And today, I want to walk you through the complete, honest picture of cardiovascular health in later life, what the evidence actually shows about the most significant risks. Which interventions have genuine, robust support? Which popular approaches are oversold? And what the most important conversations to have with your physician actually look like. Before we begin, drop a comment with your age and whether you have ever been given an actual numerical estimate of your cardiovascular risk, rather than simply a list of risk factors to manage. I read every comment, and the answers tell me how well the healthcare system is actually communicating this critical information to the people who need it. Let me start with why cardiovascular health specifically deserves this level of attention for adults over 60. Cardiovascular disease, encompassing heart attack, stroke, heart failure, and peripheral arterial disease, is the leading cause of death in most developed countries, and this reality is disproportionately concentrated in older adults. The risk of a first cardiovascular event rises substantially with each decade after 50. This is not simply because more time has passed, though the cumulative time over which arterial damage can accumulate does matter. It is because specific biological changes that accelerate cardiovascular risk become increasingly pronounced after 60. Arterial stiffness, the loss of the elastic compliance that allows arteries to absorb and buffer the pulsatile pressure waves from each heartbeat, increases progressively with age. This stiffening raises systolic blood pressure, increases the mechanical stress on arterial walls with each heartbeat, and reduces the efficiency with which the heart can work. It is measured by a parameter called pulse wave velocity, and elevated pulse wave velocity is an independent predictor of cardiovascular events, stroke, and premature mortality. Endothelial dysfunction, meaning impaired function of the thin layer of specialized cells lining the interior of blood vessels, becomes increasingly common with age. Healthy endothelium produces nitric oxide and other compounds that maintain vascular tone, prevent platelet aggregation, and control the inflammatory responses within vessel walls. As endothelial function declines, these protective mechanisms become less effective, creating conditions more favorable to the inflammatory processes underlying atherosclerosis. The accumulation of atherosclerotic plaque in arterial walls, a process that typically begins in young adulthood and progresses throughout life, reaches a point in many adults over 60 where it becomes clinically significant. Plaques that were stable for years can become vulnerable to rupture, triggering the acute blood clot formation that causes most heart attacks and strokes. Understanding what determines plaque stability and which interventions reduce rupture risk is one of the most important things I can share today. Cardiac structural changes with aging include left ventricular hypertrophy in response to the increased afterload from arterial stiffness, diastolic dysfunction, where the heart muscle stiffens and relaxes less completely between beats, and changes in the heart's electrical conduction system that increase the risk of arrhythmias, particularly atrial fibrillation. Atrial fibrillation deserves specific mention because its prevalence increases dramatically with age and because it significantly elevates stroke risk through a mechanism distinct from atherosclerosis. In atrial fibrillation, the upper chambers of the heart beat chaotically rather than in coordinated rhythm, causing blood to pool and potentially form clots. These clots can travel to the brain and cause strokes. The management of atrial fibrillation, including decisions about anticoagulation, rate control, and rhythm control, is a specialized area that requires close collaboration between the patient and a physician with expertise in this condition. Now let me address the major modifiable risk factors for cardiovascular disease in older adults, because these are the levers that are genuinely within your control. Blood pressure management is arguably the single most important modifiable risk factor for cardiovascular disease in older adults, and I say this having considered the full landscape of evidence carefully. Hypertension, defined as a systolic blood pressure consistently above 130 millimeters of mercury by current guidelines, is extraordinarily common after 60, affecting the majority of adults in this age group in most developed countries. The cardiovascular consequences of elevated blood pressure operate through multiple mechanisms. Chronically elevated pressure mechanically stresses arterial walls, accelerating atherosclerotic damage. It promotes left ventricular hypertrophy as the heart muscle thickens to generate sufficient force against increased resistance, which over time impairs diastolic function and increases arrhythmia risk. It damages the microvascular beds in the kidneys and the brain, contributing to chronic kidney disease and to the small vessel disease that underlies much of the cognitive decline and white matter changes seen in older adults with poorly controlled hypertension. The clinical trial evidence for blood pressure reduction in older adults is genuinely some of the most robust evidence in preventive medicine. Large, randomized controlled trials, including the SPRINT trial and multiple others, have demonstrated significant reductions in cardiovascular events, stroke, heart failure, and cardiovascular mortality from treating hypertension in older adults to appropriate target blood pressures. The benefit persists even in adults in their 70s, 80s, and beyond, which some clinicians previously doubted. Blood pressure measurement accuracy deserves specific attention because poorly measured blood pressure is a common source of both underdiagnosis and overdiagnosis of hypertension. The standard for accurate blood pressure measurement requires at least 5 minutes of quiet seated rest before the measurement, with the arm supported at heart level, using a properly calibrated and appropriately sized cuff. Measurements taken immediately after activity, in situations of stress or anxiety, or with the arm unsupported, produce consistently higher readings that do not reflect resting blood pressure accurately. White coat hypertension, elevated blood pressure in clinical settings due to the stress of the medical encounter, is genuinely common and can lead to overdiagnosis. Home blood pressure monitoring, using a validated device with proper technique, provides a more representative picture of typical blood pressure than measurements taken only in clinical settings. Many physicians now request a series of home measurements before making treatment decisions based on elevated readings in the office. The lifestyle interventions for blood pressure that have the strongest evidence include dietary sodium reduction, particularly through reduction of processed and packaged foods that contain most of the sodium in the typical diet, rather than focusing primarily on the salt shaker. The DASH diet, rich in fruits, vegetables, whole grains, low-fat dairy, and lean proteins, has demonstrated blood pressure reductions comparable in some studies to single medications. Regular aerobic exercise lowers blood pressure through multiple mechanisms, including improved endothelial function, reduced sympathetic nervous system activity, and weight management. Alcohol moderation, since excess alcohol consistently raises blood pressure and reduces the effectiveness of antihypertensive medications. And stress management, because chronic psychological stress maintains the sympathetic nervous system activation that elevates blood pressure. When lifestyle interventions are insufficient, which they frequently are in older adults with significant hypertension, antihypertensive medications are an essential and evidence-based component of management. The appropriate choice of medication depends on multiple factors, including the pattern of hypertension, other health conditions present, kidney function, and tolerability, and is a decision to make in close collaboration with your physician. Blood sugar management is the second major risk factor category, and the relationship between glucose metabolism and cardiovascular disease in older adults is considerably more nuanced than most people realize. Type 2 diabetes dramatically elevates cardiovascular risk through multiple mechanisms. Elevated glucose directly damages the endothelial cells lining blood vessels, impairing the nitric oxide production that maintains vascular health. Diabetes accelerates atherosclerosis, promotes inflammation within vessel walls, and increases platelet aggregation and clot formation risk. People with diabetes have 2 to 3 times the cardiovascular event rate of age-matched non-diabetic individuals and tend to have worse outcomes when cardiovascular events do occur. But here is what many people do not understand. The cardiovascular risk elevation does not begin at the arbitrary threshold that constitutes a diabetes diagnosis. It begins increasing progressively through the pre-diabetic range of glucose levels, beginning with insulin resistance that precedes any detectable glucose elevation. This means that the period during which blood sugar management is most impactful for cardiovascular protection extends considerably earlier than the point of diabetes diagnosis. The management of blood sugar in older adults with established diabetes requires careful attention to the specific risks and benefits that differ from those in younger people. In older adults, overly aggressive blood sugar lowering, targeting very low HbA1c values, can be more harmful than beneficial because the risk of hypoglycemia, dangerous low blood sugar, is higher in older adults, and the cognitive consequences of hypoglycemic episodes are more serious. Current guidelines for older adults with diabetes generally recommend less aggressive HbA1c targets than those used for younger people, with the specific target depending on the individual's overall health status, life expectancy, and hypoglycemia risk. Several medication classes used for type 2 diabetes have demonstrated specific cardiovascular benefits beyond glucose control that have substantially changed prescribing practice in recent years. SGLT2 inhibitors, including empagliflozin, canagliflozin, and dapagliflozin, have demonstrated significant reductions in cardiovascular mortality, heart failure hospitalization, and kidney disease progression in people with established cardiovascular disease or high cardiovascular risk. GLP-1 receptor agonists, including semaglutide and liraglutide, have demonstrated cardiovascular event reduction and significant weight loss benefits in clinical trials. These findings have made the choice of diabetes medication in people with or at high risk of cardiovascular disease a much more nuanced and important clinical decision than it was a decade ago. Smoking cessation remains one of the single highest impact interventions for cardiovascular risk reduction at any age, including for adults well into their 60s and 70s who may have smoked for decades. The cardiovascular effects of smoking are mechanistic and significant. Nicotine and other compounds in tobacco smoke directly damage the endothelium. Smoking increases platelet aggregation and blood clotting tendency. It raises blood pressure and heart rate. It reduces HDL cholesterol, it promotes inflammation within arterial walls, and it impairs the oxygen-carrying capacity of blood by binding hemoglobin with carbon monoxide. The beneficial effects of cessation begin almost immediately after stopping, with measurable improvements in cardiovascular function within days to weeks. The long-term cardiovascular risk reduction from cessation continues for years after stopping, with the excess risk from smoking substantially diminishing after approximately 10 to 15 years of abstinence. For a 65-year-old smoker, cessation is not too late. It remains one of the highest value health decisions available. Effective cessation support, combining pharmacological assistance with behavioral support, substantially increases success rates compared to willpower-based attempts alone. Pharmacological options, including varenicline, bupropion, and nicotine replacement therapy, are all evidence-supported. Behavioral support through group or individual counseling significantly improves outcomes when combined with pharmacotherapy. The evidence strongly supports active, supported cessation efforts rather than accepting continued smoking as an established habit that is too difficult to change. Physical activity and cardiorespiratory fitness are among the strongest independent predictors of cardiovascular outcomes in older adults, and the magnitude of their protective effect is often underappreciated. Cardiorespiratory fitness, measured as maximal oxygen uptake or estimated through exercise testing, is one of the strongest known predictors of cardiovascular mortality in older adults. Research consistently finds that low cardiorespiratory fitness is as strong a predictor of mortality as established cardiovascular risk factors like hypertension, diabetes, and smoking. This is true even after accounting for other risk factors, meaning fitness provides independent cardiovascular protection beyond simply reducing other risk factors. The good news embedded in this finding is that cardiorespiratory fitness is significantly modifiable through appropriate exercise, even in adults in their 70s and 80s who have been sedentary for years. Studies showing meaningful fitness improvements from structured exercise programs in older adults are numerous and consistent. The improvement does not need to be dramatic to be clinically meaningful. Even modest increases in fitness from a low baseline produce significant reductions in cardiovascular risk. The combination of aerobic exercise and resistance training produces better cardiovascular outcomes than either type alone for reasons that reflect their complementary mechanisms. Aerobic exercise improves heart efficiency, reduces blood pressure, improves lipid profiles, and enhances endothelial function. Resistance training improves insulin sensitivity, reduces visceral fat, maintains muscle mass, and through improving body composition indirectly benefits multiple cardiovascular risk factors. The practical exercise prescription that the evidence most consistently supports for cardiovascular benefit in older adults is 150 minutes per week of moderate intensity aerobic activity, equivalent to 30 minutes 5 days per week, combined with 2 resistance training sessions weekly. Moderate intensity means exercise that noticeably elevates your heart rate and breathing, but allows you to carry on a conversation, corresponding roughly to a brisk walk for most older adults. For someone who is currently sedentary, starting with 15 to 20 minutes of brisk walking daily and building gradually toward this target over several months is a genuinely achievable approach that produces cardiovascular benefit even before reaching the full target. The consistency of the habit matters more than achieving a specific intensity threshold immediately. Weight management deserves specific discussion in the context of cardiovascular risk in older adults because the relationship between weight and cardiovascular risk is somewhat more nuanced after 60 than it is in younger adults. Excess visceral fat, the fat accumulated around the abdominal organs, is the component of body weight most directly linked to cardiovascular risk through its metabolic effects on blood sugar, lipids, blood pressure, and inflammation. This distinction matters because body weight and visceral fat accumulation do not perfectly track each other. An adult who appears to be at a normal or even low body weight can carry significant visceral fat, producing elevated metabolic risk. And an adult with elevated body weight can have relatively limited visceral fat if their excess weight is distributed peripherally as subcutaneous fat. For most older adults, however, reduction in excess body weight through the combination of dietary improvement and increased physical activity does reduce visceral fat and produce measurable improvements in cardiovascular risk factors. The goal is not achieving a specific weight or body mass index, but rather the metabolic improvements in blood pressure, blood sugar, blood lipids, and inflammation that accompany meaningful reductions in visceral adiposity. The approaches to weight management with the best long-term evidence for older adults emphasize lifestyle-based changes rather than severe caloric restriction, which in older adults carries specific risks related to loss of lean mass, micronutrient deficiency, and reduced physical function. Prioritizing adequate protein intake, 30 to 40 grams per meal, while improving dietary quality through increased vegetable variety, whole grains, and reduced refined carbohydrates and added sugars, supports weight management while preserving the muscle mass essential for physical function. Mental health and psychological well-being are cardiovascular risk factors that remain significantly underappreciated in clinical practice. Depression is associated with substantially elevated cardiovascular risk in older adults through multiple mechanisms. It promotes inflammatory responses, increases platelet aggregation, disrupts the autonomic nervous system balance towards sympathetic dominance, reduces adherence to health behaviors and medications, and is associated with elevated cortisol that damages the endothelium over time. Depression in people with established cardiovascular disease is associated with worse outcomes following heart attack and worsened prognosis in heart failure. Chronic psychological stress produces similar cardiovascular effects through sustained sympathetic nervous system activation, elevated cortisol, and the downstream effects of these on blood pressure, inflammation, and clot formation. The evidence that effective stress management improves cardiovascular outcomes is less robust than the evidence for pharmacological interventions, partly because stress management is harder to test in randomized trials, but the biological mechanisms are sound, and the absence of meaningful side effects makes stress management practices a reasonable component of a comprehensive cardiovascular risk reduction approach. If you are experiencing depression or significant chronic stress that you are not actively addressing, raising this with your physician is a cardiovascular health concern, not only a mental health one. What does meaningful engagement with your own cardiovascular health actually look like in practice? Know your numbers, your blood pressure, ideally through consistent home monitoring rather than occasional clinical measurements. Your lipid panel, including LDL, HDL, triglycerides, and ideally apolipoprotein B or particle counts for a more complete picture. Your fasting glucose and HbA1c, your body weight and waist circumference, and ideally your estimated glomerular filtration rate for kidney function. These numbers together, reviewed with your physician, should be the basis for a specific, calculated cardiovascular risk estimate rather than a vague discussion of general risks. Establish your actual 10-year cardiovascular risk. Ask your physician to calculate this using a validated risk calculator. Different calculators exist for different populations, and your physician can identify the most appropriate one for your demographics and health background. Knowing that your 10-year cardiovascular risk is, for example, 15% changes the cost-benefit calculation for specific preventive interventions in ways that knowing you have high blood pressure and elevated cholesterol does not. Engage actively with treatment decisions rather than passively accepting recommendations. When a medication is recommended, ask why. What evidence supports it for someone with your specific risk profile? What the expected magnitude of benefit is, and what the risks and alternatives are. When lifestyle interventions are recommended, ask how much improvement is realistically expected from that specific change given your baseline, and what timeline is appropriate before evaluating whether additional interventions are needed. Do not delay seeking evaluation when symptoms occur. The classic symptoms of heart attack and stroke are widely known, but their recognition and appropriate urgency of response is not universal. Chest discomfort, pressure, tightness or pain, often described as something heavy sitting on the chest, is the most common presentation of acute myocardial infarction. Shortness of breath, cold sweat, nausea, or lightheadedness accompanying chest discomfort increases the urgency further. The sudden onset of face drooping, arm weakness, speech difficulty, or severe unexpected headache are the classical warning signs of stroke requiring immediate emergency evaluation. Acting quickly when these symptoms occur, rather than waiting to see if they pass, is among the most important things anyone over 60 can know. But equally important is not dismissing atypical presentations. Women, older adults, and people with diabetes are more likely to experience heart attacks with atypical symptoms, including jaw pain, back pain, unusual fatigue, or shortness of breath without prominent chest discomfort. The combination of several of these symptoms together, particularly if they are new or unusual for you, warrants prompt medical evaluation rather than reassurance that they are probably nothing. Let me close with the perspective I most want to leave you with. Cardiovascular disease is not fate. It is the product of decades of biological processes, many of which are significantly influenced by the choices you make and the medical care you engage with. The evidence for this is not wishful thinking. It is some of the most robust evidence in all of medicine, produced by randomized controlled trials involving hundreds of thousands of people and decades of follow-up. The window of opportunity for meaningful cardiovascular risk reduction does not close at 60. It remains genuinely open through your 60s, 70s, and beyond. The interventions produce real benefit. The benefit is measurable. And the conversations that make those interventions possible start with you knowing enough to ask the right questions. This is Dr. John. Your heart has been working for you every second of your life. Give it the attention it has earned. I will see you in the next one.